Hello, friends. I'm Dr. Anurag Mishra, and today I'll be talking about a topic which is very critical for all of us. I think being a surgeon and trainees, day in, day out, we are dealing with sick patients, but either when they come to emergencies or casualties, or let's say after surgery, some patients deteriorate in wards when they are admitted with serious diseases. They deteriorate. Now, at that point, as a resident, we struggle to check all the things to find out what is happening, to ascertain the cause, and then to start appropriate treatment. And many of the times during these events, when the consultant will come and they will ask a very simple question that, did you do this? Did you measure ABG? And suddenly we say, oh, we did not think about that. So what today I will try to do is we'll try to have built an algorithm-based system where you can assess any sick patient. Now you have known about some algorithm-based like ATLS and ACLS. This system is also a kind of extension of that. So you'll not be very uncomfortable or learning something very new, but we will try to use similar algorithm and see whether it can be applied on patients which are non-trauma or non-arrest patients. And this concept has been used and is being used widely worldwide. Uh, I also am a part of a trainer who conducts these courses based on this particular modality. We call this ACCC or Acute Critical Care Course. And so I will tell you today about how, in an algorithm based, very easy way, you can ascertain uh, almost every sick patients in your ward. It can also be applied in medical patients of diabetes and hepatic failure or renal failures and all those things, which are always a kind of a fearful condition for us because they're very complex. But in my experience, if you go stepwise, you'll be able to handle these situations with quite an ease. So let's get on with it. Now, as you see in the slide, you can see very familiar ABCDE, but then you see a further extension of 5 more levels. And so that is what we are going to study today. Now, again, a very common scene when a patient is wheeled into emergency, we are expected to promptly diagnose and immediately start the treatment so that the patient survives. And certain delay in decision making or ascertaining the cause here can lead to death of these patients or very grave complications, which nobody of us wants in that way. So that is the importance of algorithm-based protocols. What objective of this session is that we will see how we can assess and resuscitate a patient simultaneously, and also what all to monitor to detect the problems in the patient. So it can be lead lack of improvement or deterioration or complications or interventions, and also to understand the underlying disease process. So this is what we'll try to see today. Also, we'll try to see what are the various pitfalls and which we need to be aware of. This is a very important term which we'll keep using again and again, that trend is friend. Now, a simple value of, let's say, a hemoglobin of 8, you may say, okay, this is okay. Patient can still survive on this. But if I tell you that 1 hour back, the hemoglobin value was 12 and now it is 8. Now, suddenly this becomes a difficult situation. Or let's say 2 hours back, the hemoglobin level was 6 and now it is 8. Suddenly the picture is very promising. So rather than absolute values, what we will emphasize is that trends is what we need to see. And that's why repeated values, repeated history, repeated examinations, repeated evaluation is what we'll talk about in this. Also, you should know what your team can do, what you can do, what you cannot do, and do not try to venture into areas which you are not comfortable with you, because in that heroism, in that thing, we can do more harm. And as per the the core basic principle of medicine, we should not do further harm to the patient. So if I don't know how to do a intubation or tracheal intubation in one go, I think I will maintain a bag and mask ventilation till an expert comes, rather than trying to attempt uh, intubations and wasting a lot of time in that period. Okay. Early referral, if the condition requires an expertise care, is always a good idea. So early referral to an appropriate institution is always a good strategy. So this is the main algorithm. So we'll start with A, which is the primary assessment and resuscitation will go on hand in hand. So when there's the first stage is A, which is airway and correction of airway if there is any problem. We all know the principles from ATLS and ACLS, that how to look, listen, and feel to look for various airway obstructions. We'll talk in detail. Then B is breathing, which is about respiratory systems. Now, why A and B are top right there at the top? Because they are the very fast killers. So these two can kill within minutes, not it was. Whereas circulation, head injuries, other peripheral injuries can still take some hours to kill a person. So that's why A and B are always our priority, even if the patient is bleeding and a lot of things, but airway is not compromised. I think we have to focus on airway first. Then C is circulation. D is disability in the standard ATLS, but we have added here dextrose and drugs. Dextrose is normal blood glucose values. And at this point, we should see what all drugs are going on and if there is a need to start any drugs to the person. So this is to encompass and widen the horizon of this ABCD protocol. So to cover other diseases and hypoglycemias and other things. So dextrose and drugs have been added in D. E is exposure, where a detailed body examination and history and everything will be done. Then comes the secondary assessment. Once these are the five primary are handled, then we move to F, which is fever, fluid, and Foley's. G is gastric tubes and other tubes of body. H is taking a history and doing a head-to-toe examination. I refers to investigation, which we'll order according to our assessment. And then J is the judgment when we create the final report or final plan of that person. So we have to follow these 10 steps and we'll be able to find answers to many of our questions related to the patient. So as we've talked, airway, breathing, circulation with stopping of hemorrhage, dysfunction of CNS along with dextrose and drugs, and exposure is what is protocol. Now, the first thing while assessing airway, or the first thing is you ask what is the patient's name and what happened. Now, this also will give you some context that what happened or what are the symptoms, but also it will tell you a fair bit of idea about the airway, breathing, and also some circulation, and even to some extent about the consciousness of the person. So by just two questions, which will take maybe 10 seconds, you will be able to answer A, B, C, and D. So this is the beauty of these two questions, just asking a name and what happened. It creates rapport. It gives you some essential information about symptoms and what was going on, and also assessment of ABCD. Okay, so coming to A properly, remember the principle of look, listen, and feel. Now here you need to look with your eyes for the air breathing out, the movements of the chest, movements of the nostrils. You have to listen for the breath sounds, for any other sound, any added sound, like stridor. You need to see. Also, you need to feel for the movement of the air from the nostrils while patient is breathing. So look, listen, and feel whether the patient is talking normally. If patient is talking normally, that means the airway is pretty okay because he's able to create a sound, which happens because the voice will flow. Is the patient alert and oriented? Just try to have that. Also, try to have a high index of suspicion. Now, especially in wards when the patient is admitted,